Hi, and welcome to AAHPO's American Armenian Health Professionals TV Health Program. We have a topic today that it's not uncommon, and it can affect men and women and at any age, and it is seizure or epilepsy. And we have a specialist here. She's from Yale University, Epilepsy Department, Dr. Aline Herlopian. She's assistant professor at Yale University. Dr. Herlopian, welcome to our program.
Thank you. Nice seeing you too.
Seizure, epilepsy, these two terminology that is very commonly used. Can you tell us what is seizure or epilepsy? How we describe that? What would we say?
Sure. So seizure is basically the definition of a seizure. It is the abnormal firing of the brain cells, and it causes an abnormal activity, which is seen either by loss of awareness or an unusual movement that the person displays. Seizure can have different clinical features. It can be from a very small activity, or it can be a big convulsion where everyone sees it as the person is on the floor and is shaking in all his limbs.
We have many types of seizure. Obviously, they present different ways, and then we should make the people aware that there are different types of. What types of? Anyway, let's talk about the types of the seizure.
The new classification, the new terminologies for the seizure is currently we use generalized convulsion, and we say this is the generalized tonic-clonic seizure. When we say grand mal seizure, this is the very old terminology where we don't use it anymore. And people in the past used to refer to a major convulsion as a grand mal to say how intense their seizure was.
Right.
So if
But actually, it could have been the other way too.
Exactly, exactly. So to talk about what types of seizures we have and how to classify them, we have two types. One, we call it focal seizure, and the second, we call it the generalized seizure. If we talk about focal seizures, we have, for example, something that starts from a particular site of the brain, and then it can spread everywhere around the brain. So it starts at a particular area, particular region. This, whatever the person does, depends on the site where the activity starts from. For example,
what symptoms they would have, let's say.
Exactly. So whenever the person has the seizure starting from the language area, he might stop talking, he might just like stare, he might understand you, but he might not respond. So this is a language center focal seizure.
And it can be short, it can be long, actually.
Exactly. It can be sometimes up to 10 seconds, or it can be up to a minute. And if it's a very long, persistent seizure, it can last for more than 5 minutes. So this is in terms of focal.
People might not even realize that the person is actually having a seizure.
Exactly.
At a particular time.
Exactly. I have patients who sometimes they say, I have a feeling that the seizure is coming, and this is called the aura, where they talk about something, a sensation, a feeling that's coming up.
We'll talk about that. Let's talk about that aura, because it's important. Sometimes every patient presents or actually feels different things that's coming. What is the most common things that they feel first? They tell you that?
Yes. So to define aura, aura is again a focal seizure where the person does not lose awareness. So that's how we describe it. Aura, a seizure without loss of awareness. It depends on where it is starting from. If the aura comes from the area where your vision is controlled, you will see flashing lights, zigzag lights, snowballs, rainbow. If it comes from an area where it controls your memory, or an area that's called the hippocampus, a part of the brain, you would have this deja vu sensation as if you have been in that place. Or you might have
a small smelling sensation, part of it.
A smell, or let's say a hearing. So you might have all these sensations, a taste, a metallic taste, nausea. Some people say they feel butterflies in their stomach. So they have a mixture of sensations.
And usually patients, if they have the seizure, they know if they have that, their seizure is coming. Actually, they can inform people around them that I might be having seizure.
Exactly. So there are some people who have these auras, and their auras last longer. And they're lucky for them to alert people, or they can go and have a seat. Exactly. And they can just rest and let the seizure go and pass. So this aura, it varies. Some people might remember the aura after the seizure. Some people might not. So that's also variable among patients. So this is the small aura.
So aura is really kind of telling them that, okay, you are getting a seizure. So that actually is very important. So this is for, let's talk about the generalized seizure now. Do they get the same thing?
Okay, so again, generalized seizure, we always classify, did it start from a particular part of the brain? If it starts from a particular part, it's called focal. It can be aura or focal seizure with loss of awareness, and then it can propagate, which means goes all throughout the brain and results in a generalized convulsion.
Right.
So in that situation, it means it started from one place and rapidly spread to the whole brain.
The brain.
Exactly.
And then now
exactly.
Generalized.
And then they
symptoms
fall.
that are coming
Exactly. Now, sometimes you have types of epilepsies which are mostly, they come in the childhood category or in the teenage folks, and those are the ones that we call generalized seizures, like the absence seizure. In 10 to 15% of these patients, sometimes they have an aura, which is usually a lightheadedness. They feel lightheaded,
Right.
funny.
So let's talk about now, as you said, febrile seizure then, because sometimes the seizure comes from childhood on, and sometimes start with febrile seizure, which fever that initiates the seizure, and sometimes it can start in childhood without fever. So let's talk about a little bit of possibly benignness or presentation of febrile seizure for children. Some people might have their kids having fever and having seizure.
So in childhood, seizures are of different categories. The most common of which is the febrile seizure, and this happens from birth up to 6 years of age. So those seizures always are associated with fever and febrile illnesses. For example, and not necessarily you have to have the fever at the time of the convulsion. It might precede it or it might come afterwards. So what happens is those patients, those are babies, and they have high fever and they have a generalized convulsion. Their all limbs shake, and usually it lasts for a minute and it subsides afterwards. And for those patients, we do not treat them as having epilepsy, but what we treat them as having a seizure that is a response to the fever.
Right.
So you give
the infection actually.
Exactly. And then you try to give them a diastat, which is a medication that is given rectally, and this is in the attempt to abort the seizure when it lasts more than 1 minute. So this is the only medication that is given. It's a rescue medication.
Right. So it's really very scary for the parents to have a baby and baby is seizing and they're so scared they don't know what to do. They have a million questions in their mind. So it really just answers for them the question saying that this is a benign possibly. If we treat the fever, seizure will go away. And you said that up till age 6.
Yes.
Now, if it persists more than 6 years old person, what do we think about at that time?
So in those situations, usually we have other syndromes that the kids do have, and this is mostly genetic. So they do come with convulsions, and they have other types of seizures as well, in addition to the febrile seizures. So in those situations, you have to alert the pediatrician, and the pediatric neurologist has to be alert that this might represent a syndrome, which is a Dravet syndrome. And it's important for us to know about it because you need the genetic workup, and you need to identify if other members of the family are at risk of having it. And also the treatment is different because there are specific medications.
Really the treatment.
Exactly. Yes. And there are specific medications. When you diagnose Dravet syndrome, you cannot give them. And this is the carbamazepine, the sodium blocking agents.
Right.
You cannot give this medication. So it's important to know, one, for treatment, and second, for counseling.
So the genetic counseling definitely is going to be there if it persists. Okay, so then we are saying that some genes, genetics can play a really actual role in the seizure. So if we talk about in general, is there any cause for the seizure? If a patient is having a seizure and comes and says, I'm having a seizure, why am I having the seizure? What is the answer for them? What are the causes?
So usually 60 to 70% of the patients, we do not know the cause. And this is what, if you read the articles or literature, they call it cryptogenic, which is we don't know the cause. There is a cause, but we are not at the technology to identify it.
It's like 60 to 70, a large portion of the patients.
Exactly.
Right.
And then the rest of the population is either scarring of a part of the brain or trauma, like concussion, or someone had a car accident, has a brain bleed, that causes it, strokes, meningitis, brain infections, tumors. So all these, they play a role also in the cause of epilepsy.
So then the patient comes to your office, either referred by primary care physicians or sometimes they refer themselves, obviously.
Exactly.
So what is the workup for them? So they come to your office now, you have to start the workup to make sure this is really seizure, but not other diseases.
Exactly. So first to clarify, when we say, first of all, when the person comes with an acute neurological symptom, which we suspect this is a seizure because it resolved within a few seconds or a minute, we have to make sure we're not missing the other causes, like cardiac causes or syncope because of a cardiac arrhythmia or a migraine phenomenon. Once you have these non-epilepsy, non-seizure causes ruled out by workup, then you start working up if this is a seizure and does this meet the criteria of epilepsy. And to just clarify what epilepsy and the seizure, how we use it. So the current diagnosis of epilepsy, it includes 2 unprovoked seizure, which means if, for example, you drank alcohol and you had a withdrawal seizure, that's a provoked seizure, so you don't have epilepsy, even if you have hundreds of them in your lifetime.
You have a seizure that's
exactly
provoked by an alcohol.
Exactly.
And it can be provoked by other things too.
Exactly.
We'll talk about later on,
exactly.
But let's continue.
Exactly. So when you have a patient who has epilepsy, or you establish the diagnosis, you want to establish diagnosis of epilepsy, you need for EEG.
Okay.
Let's say a person comes with 1 unprovoked seizure. Out of the blue, he was driving or he was doing a regular activity, he had a seizure, and that's 1 seizure. So you have workup to be done. So you have to identify what caused that seizure. So in that workup, you have MRI brain. You have to do it.
Abnormalities in the brain structure.
Exactly, exactly. And you have to do it in specific sequences and specific cuts for you to see the details of the brain.
Right.
And then you have to do EEG for you to see if there's abnormal sparks, abnormal activity, if there's any focal problems in the brain, or there's generalized problem in the brain.
Right. So EEG, they put certain
leads,
probes on their brain, on the skull, and then they, and
Yeah.
how long they stay usually? 45 minutes, an hour?
So
or so?
it depends, yes. The routine, the one that they do it, sometimes it's 20 minutes up to 1 hour. It happens also in a specific lab, and it has lots of electrodes. They apply it on the brain.
skull, right?
And then what they do is they ask you, for example, they ask you a few questions during the recording, and then there are 2 provocative maneuvers, like the hyperventilation, which this is primarily for the babies and the kids, for them to hyperventilate and induce specific type of brain activity that's a marker of epilepsy.
Something.
Exactly. Or the photic stimulation, which they use a high strobe light frequency, and they shine it into the patient's eye and try to see if that provokes a spike or not.
What is the accuracy of EEG diagnosing really epilepsy?
So the first EEG that you do is 50% chance of having an abnormality, and if the first one is abnormal, then you do 3 more, and the third has a yield of 90%. Now bear in mind that if you have a normal EEG, that doesn't mean you do not have epilepsy, because that EEG is like a snapshot of a particular time frame of your brain at a specific point. So if we record you for like 72 hours continuously, we might find an abnormality. So you have to go by clinical diagnosis.
Right. So if it's the first time they do an EEG, it might be normal. Then if the person comes with another seizure, then you're really now suspicious that probably you have a longer EEG this time, just to document that they have epilepsy or not.
So in that situation as well, if he comes with the second seizure, the second unprovoked seizure, then that's already an indication for you to start the anti-seizure medication. So the only trick here is if you have 1 unprovoked seizure plus all the workup is negative, which means everything is normal, then you're at a dilemma. Should I start the medication or should I not? Usually we do not start the medication, and then we wait for the second event. If the second event happens, then we start the medication. However, if it's the first event plus an abnormal EEG, an abnormal MRI, we usually exactly.
And then we go from there.
Exactly.
Dr. Herlopian, thank you very much. We will be continuing on the second part of this to talk about the treatment of it. Good health is precious and priceless. Visit AAHPO's website for up-to-date medical information. I'm Dr. Ohan Karatoprak. Until next program, so long.